Hello everyone, welcome. Today I'll discuss about lipoproteins and dyslipidemia. So let's first start with lipoproteins. As you can see the name, the name, it has a lipid portion and a protein portion. The main portion is the lipid portion. So here is a nice ball of lipoprotein, and in the outer surface of the ball, the blue portion is actually a phospholipid membrane, and in between the phospholipid molecules you have some unsterified cholesterol. So this phospholipid membrane is actually mainly a lipid membrane, and inside, in the core of the lipoprotein molecule, you have some lipids like triacylglycerols, cholesterol, and cholesterol esters. And as you know, this molecule now becomes a very fatty molecule, and fats are fats are very tough to be transported through your blood. Okay, and that's why you need something to help it transport through blood, and here comes the helper molecule, which is the apoprotein. So apoprotein actually increases the water solubility of the lipoprotein molecule, and that's why the lipoprotein molecules can be easily transported from anywhere to anywhere in your body. This is the basic structure of a lipoprotein molecule. Now we have the different lipoproteins, and most common lipoproteins are Chylomicron, very low density lipoprotein, and high density lipoprotein. As you can see, this classification is mainly based on density. So Chylomicron has the lowest density and HDL has the highest density. And as you can see, the specific gravity of Chylomicron is less than 1, and the specific gravities of other molecules are increasing. And that's why if you take a test tube and put all the molecules here, the lowest molecule will be HDL, then will be LDL, then VLDL, and the uppermost supernatant portion will be formed by chylomicrons. Okay, that's the basic idea. Here we have the chylomicron metabolism. So chylomicron is a molecule actually which forms inside your small intestinal cells, and when it forms, it has a lot of triacylglycerols and some cholesterol ester and some cholesterols. And as I have already mentioned, that those lipids are actually insoluble in your blood because blood has a very watery solution, and that's why you need to tag it with the apoprotein. And for nascent chylomicron, the apoprotein is ApoB48, which is very specific for chylomicron only. Remember that, please. And when the chylomicron comes to blood, then chylomicron meets HDL, the big brother HDL, and HDL calls out to chylomicron, "Hey you chylomicron, you need some ApoC2 ApoE?" And then chylomicron calls up to HDL, "Yes big brother, please give me some ApoC2, give me some ApoE." HDL asks chylomicron again, "Why do you need them? Can you tell me how you're gonna use them?" Then chylomicron calls, yes, I'm gonna use them, especially the ApoC2, to cut my fats, especially cut my triacylglycerols to produce free fatty acids and glycerol, and I will use my ApoE2 to end my journey in the liver. Okay, then HDL gives those ApoE and ApoC2 molecules to chylomicron happily, and now chylomicron has actually 3 apoproteins. One is ApoB48, another is ApoC2, and another is ApoE. And then chylomicron begins a journey through the capillaries, and when it comes to tissues, here he finds a very important enzyme which is called lipoprotein lipase, and now the ApoC2 comes in handy, and ApoC2 actually activates the lipoprotein lipase, and when ApoC2 activates lipoprotein lipase, it actually cuts the triacylglycerols into free fatty acids and glycerol. So ApoC2 helps triacylglycerol to cut into 2 pieces. Okay, C2 for cutting into 2 pieces. Remember, in that way. And then when this job is over, then ApoC2 is actually again given back to the HDL with thanks. And then chylomicron is only having 2 apoproteins. One is ApoE and one is ApoB48. As ApoE helps the ending of the journey of chylomicron in the liver, so chylomicron is then the ApoE will bind to its specific receptors on the liver and helps the chylomicron to be absorbed or endocytosed in the liver. So this is the basic pathway of metabolism of chylomicron. Okay. Now comes the VLDL and LDL. So VLDL is actually synthesized from liver, and it has the same structure, almost the same structure like chylomicron. It has a lot of triacylglycerol, a bit of cholesterol ester, and a bit of cholesterol. But the apolipoproteins of VLDL is a different one, which is a ApoB100, and you can contrast. Chylomicron has ApoB48 and VLDL has ApoB100, and with this apolipoprotein, the VLDL gets out of the liver, and then comes the big brother HDL, again calls out to VLDL if he needs any ApoC2 and ApoE, and again VLDL requests the HDL to give him ApoC2 and ApoE because he will later use them, and so the HDL gives them happily, and so now VLDL has ApoC2, ApoE, and ApoB48. And again, like the chylomicron did, the ApoC2 helps the VLDL to activate lipoprotein lipase, which will actually cut down the triacylglycerol into two parts. One is free fatty acid and another part is glycerol. So again, ApoC2 helps you to cut down the triacylglycerol into two parts, C2 cut in two, and then VLDL will be converted to IDL, also known as intermediate density lipoproteins, and then the IDL will actually transfer the ApoC2 and ApoE back to HDL with thanks. And now the IDL is actually converted to another important molecule which is called LDL, and LDL is actually only left with some ApoB100, and also it has a decreased level of triacylglycerol, so it has a higher amount of cholesterol ester and cholesterol, because as the triacylglycerol are already broken down by lipoprotein lipase in the tissue spaces. So now the LDL has actually two fates. LDL can either go to the tissues where there is LDL receptors which can uptake the LDL and use the cholesterol inside the LDL, and again LDL can come back to the liver and bind to the LDL receptor and be endocytosed and taken up by the liver. But those two fates are the most common fates of LDL. Okay. So we can actually combine the metabolism of chylomicron and VLDL, LDL, IDL together. So here we have the intestines. So if you ingest some fat, your fats will be digested and then it will be absorbed by your intestinal mucosal cells, where they will be formed through a big molecule which is chylomicron. So remember, chylomicron has ApoB48 and a lot of triacylglycerol, and then the ApoC2 helps activate the LPL or lipoprotein lipase, and this will actually help the breakdown of triacylglycerol to free fatty acid and also glycerol. And now if the chylomicron is the fat inside the chylomicron is broken down, now the chylomicron will be called the chylomicron remnants, and which will be actually taken up by the liver. And one thing that helps this process is ApoE. So ApoE helps the ending of journey of chylomicron. And here you have the liver, which actually produces VLDL. Again, the VLDL has mainly ApoB100, but later on HDL gifts it with ApoC2 and ApoE. And ApoC2 again helps the activation of LPL, breaks down the triacylglycerol inside the VLDL, and that's why there is release of free fatty acid. And after that, the VLDL has a decreased content of triacylglycerol, becomes something called IDL. And IDL still has the ApoE and ApoC2, and then the IDL actually will release the ApoE and ApoC2 and give it back to the HDL, and then it becomes the LDL. So LDL is only left with ApoB100 and some cholesterols and cholesterol ester. So this LDL has two fates, can go either to the tissues or to the liver. So this is the basic metabolism of the lipoproteins. So the most important enzymes that I have already discussed, one is lipoprotein lipase. So it helps the degradation of triacylglycerol or triglycerides in chylomicron and VLDL. And this lipoprotein lipase is actually activated by ApoC2. Remember that, very important to know. And this lipoprotein lipase is actually found in vascular endothelial surface. And another enzyme which is less important is hepatic triglyceride lipase, which helps the degradation of triglyceride which is remaining in intermediate density lipoprotein. But the more important enzyme is hormone sensitive lipase, which is actually found in tissues, which help the degradation of triacylglycerol stored in adipocytes. And there are two other enzymes. One is lecithin cholesterol acyl transferase, which actually catalyzes the formation of cholesterol ester from cholesterol and glycerol. And there is another protein which is known as CETP, or cholesterol ester transfer protein, which actually helps the transfer of cholesterol ester molecules from one type of lipoprotein to another type of lipoprotein. So you can actually summarize the apoproteins or apolipoproteins present on different type of lipoproteins. And as I have already mentioned, for chylomicron, the most important lipoprotein or apoprotein is B48, ApoB48. It is present from the birth of chylomicron. And for VLDL, the molecule that is present from the birth of VLDL in the liver is ApoB100. Okay, so this is the very important molecule to note. And for HDL, the molecule that is present from the birth of HDL is ApoA1. And HDL has some two other apoproteins, which are ApoE and ApoC2. So ApoE and ApoC2 are actually some helper molecules which are given to chylomicrons and also given to VLDL from HDL. So I have already mentioned ApoC2 helps the chylomicron and VLDL to activate the lipoprotein lipase and release fat, and ApoE2 helps the chylomicron to end its journey. Okay, this is the most important things. And also you can remember that in HDL the ApoA1 actually activates alkate or lecithin cholesterol acetyl transferase, which actually helps the esterification of the cholesterol molecules. Okay, this is the basic. So I'm actually reviewing it again. So chylomicron, the major function of chylomicron is delivery of dietary triglyceride to peripheral tissue, and also the remaining cholesterol will be delivered to the liver. And VLDL, the main job is delivery of hepatic triglyceride to peripheral tissue. And for IDL, it is actually a degradation product of VLDL, which delivers triglycerides and cholesterol to liver. And those two are the most important lipoproteins, LDL and HDL. So LDL is a bad one and HDL is a good one. LDL is a bad one because it actually delivers hepatic cholesterol to peripheral tissue, where actually it helps the formation of atherosclerosis. But HDL actually causes the reverse transport from periphery to the liver, and HDL is actually synthesized from both the liver and intestines. So now we have some disorders of lipoprotein metabolism, and the first one is type 1 dyslipidemia. And the major problem in type 1 dyslipidemia is hyperchylmicronemia. It actually occurs due to a defect in lipoprotein lipase or altered apolipoprotein C2. So if I go back to our previous slide of chylomicron metabolism, as you can see here the triacylglycerol inside the chylomicrons will be broken down by lipoprotein lipase. So if there is any defect in lipoprotein lipase, there will not be any breaking down of triacylglycerol. And also, if there is any defect in ApoC2, the lipoprotein lipase will not be activated, and so the levels of chylomicron and levels of triglycerides in your blood will be very high. Okay, so this is the basic defect. And so as you see here, there will be increased level of chylomicron mainly, and also there will be increased level of triglycerides because you are actually inhibiting, or there is decreased function of lipoprotein lipase, and also there will be increased cholesterol. This is an autosomal recessive condition, and the excessive triglycerides actually can deposit in different type of tissues, like in pancreas causing pancreatitis, in your liver and spleen causing hepatosplenomegaly, and also under your skins producing eruptive or pruritic xanthomas. But the most important thing to remember for type 1 dyslipidemia is that there is no increased risk for atherosclerosis. This is a very important point. And also it's very easy to remember that in case of type 1 dyslipidemia, there is excessive chylomicrons, and as the chylomicron density is less than 1, it will actually float in the surface of any fluid, and actually it will form the creamy layer of supernatant. And type 2 Dyslipidemia is called familial hyper-cholesterolemia. It is the most dangerous one and the most important one. And here, as you can see, there is absent or defective LDL receptor. So we can actually go back to our previous slide here. So here you can see, here is the LDL molecule, and it has two fate. It can either go to the liver or it can go to the extrahepatic tissue. So if there is any defect in the LDL receptor, it cannot be taken up by either liver or by the tissues, and that's why the LDL will build up in your blood, build up, and as LDL has a lot of cholesterol, the cholesterol level will be up. Okay, so the cholesterol level will be up, and there will be increased LDL, increased cholesterol, and this is a autosomal dominant condition. And if the patient is heterozygote, there will be cholesterol level of about 300 milligrams per DL. But in rare cases, the patient can also be homozygotes, and it will have a double amounts like 600 or 700 milligrams per deciliter of cholesterol. And very important to note, in case of those patients, unlike type 1 dyslipidemia, there will be accelerated atherosclerosis. Even some patient can have MI before 20 years of age. And the typical pathologic findings are that deposition of cholesterols in different parts of your body, like in your tendons, Achilles tendon, forming Achilles tendon xanthoma, and also in the margin of the cornea, forming corneal arcus. So here you can see a patient with type 2A dyslipidemia, and where there is a formation of xanthoma in the Achilles tendon in his right leg. Also there are some other xanthomas here. And here you can see a patient with type 2A dyslipidemia, where there is formation of corneal arcus. So this white area is the corneal arcus, where actually there is deposition of cholesterol and cholesterol esters in the cornea, forming the corneal arcus. Okay, so one last dyslipidemia is type 4 dyslipidemia, which is also known as hyper-triglyceridemia, and it actually occurs due to hepatic overproduction of VLDL. So we can actually go back to our previous discussion, and you can see here the liver actually is the production site for VLDL. So if the liver produces a lot of VLDL, and as VLDL has a lot of triglyceride like that of Chylomicron, so there will be an increased amount of VLDL and increased amount of triglyceride. Okay, so as you can see, there will be increased VLDL and increased triglyceride, and it is also like the type 2A dyslipidemia. It is also an autosomal dominant condition, and the main problem is there will be a lot of triglycerides, like more than 1000 milligrams per deciliter of blood, which can actually deposit in your liver, deposit in your pancreas, and it can cause pancreatitis. So that's all from me today, and thanks for watching my video, and stay tuned for more